All right, fluid and electrolytes, acute kidney injury. There's your required readings. Here's our objectives. So the healthy kidney, what are we going to see with healthy kidneys? Blood flow to the kidneys from the heart is about 20 to 25% of our blood flow will go to the kidneys. And a person should excrete a minimum of 400 to 600 mLs of urine daily to clear all toxins and waste products. So you're going to want to excrete at a minimum 400 to 600 mLs of urine daily. So some roles of the kidney. Our kidneys filter out toxins and waste products. They maintain our body fluid volumes. They also regulate our acids and bases. So kidney reabsorbs bicarbonate before it is secreted or excreted if you're too alkalotic. If you're too acidic, remember it takes hours to days for the kidneys to respond with bicarb. So for regulating our blood pressure, remember we have the renin-angiotensin response. So that's that RAS. That's where plasma renin is carries out the conversion of angiotensinogen, which is released by the liver, to angiotensin 1. I know you guys have already gone over this. We're just going to go over it again. I know it was covered in detail a couple lectures, or maybe the last lecture you guys were in. So it's released by the liver to angiotensin 1, and then angiotensin 1 is subsequently converted to angiotensin 2 by the angiotensin converting enzyme found on the surface of vascular endothelial cells, primarily in the lungs. Angiotensin 2 is a potent what? Vasoconstrictor, remember? It causes blood vessels to narrow, resulting in increased blood pressure. Angiotensin 2 also stimulates the secretion of aldosterone from the adrenal cortex. Aldosterone then causes the renal tubules to increase the reabsorption of sodium and water into the blood, while at the same time causing that excretion of potassium. This increases the volume of extracellular fluid in the body, which also increases blood pressure. The kidney also produces erythropoietin for red blood cell creation. And it converts vitamin D to an active form. It also maintains electrolyte balances. So what is the etiology of acute kidney injuries? You can have a rapid loss of kidney function, ranging from slight deterioration to severe impairment. Acute kidney injuries is most common in acute care settings. Approximately 5% of all hospitalized patients develop acute kidney injuries. The incidence jumps to as much as 30% in critical and specialty care units. The mortality rate for acute kidney injury in seriously ill patients is up to 75%, particularly in older adults and the critically ill. The onset can be sudden, it can be hours, or it can be days. Sudden kidney decline means that 50% of the kidney nephrons are functioning and the other are being overworked. So that's in a sudden decline. 50% of the kidney nephrons are functioning and the other nephrons are being overworked. The kidneys may start to show signs of kidney decline. The duration of acute kidney injuries can be from 2 to 4 weeks to months. The prognosis is good if we give our patients supportive treatment to recover from the kidney injury. And acute kidney failure has a high mortality rate, typically because the patient has other life-threatening complications. About half of all patients who develop acute kidney injuries during hospitalization are older than 60 years old. There's a normal physiologic decrease in the kidney function associated with aging. This also puts older adults in greater risk for acute kidney injuries. So here's some terms to know. First one is anuria. It's a total urine output of less than 100 mils in 24 hours. So less than 100 mils in 24 hours. Azotemia is increased blood urea nitrogen and serum creatinine levels, suggestive of kidney impairment, but without outward symptoms of kidney failure. Yep, azotemia is increased blood urea nitrogen and serum creatinine levels, suggestive of kidney impairment, but without outward symptoms of kidney failure. Oliguria. This is where you have a decreased urine output. The total urine output is between 100 and 400 mLs over 24 hours. So it's between 100 and 400. And then polyuria is that increased urine output, like we talked about in the diabetic patients in DKA. Total urine output is usually greater than 2,000 mils in 24 hours. 2,000? Greater than 2,000, so greater than 2 liters in 24 hours. Uremia, that's the accumulation of nitrogenous waste in the blood as a result of kidney failure. Sometimes this is referred to as uremic syndrome. So this is just the accumulation of those nitrogenous wastes like creatinine and urea in the blood as a result of kidney failure, sometimes referred to as uremic syndrome. So what are some signs of uremia? You can have a metallic taste in your mouth. You can have anorexia, nausea and vomiting, muscle cramps, itching, fatigue, hiccups, edema, dyspnea, and paresthesias. Paresthesias, am I loud enough for you guys? Or do you want me to speak up? Okay. Did you guys get that? I didn't want to use the microphone because I felt like it caused like an echo. on the recording. So the pathophysiology behind acute kidney injuries. These patients will have a rapid decrease in kidney function. The onset is sudden. With a pre-renal injury, they have a reduced blood flow to the kidneys. That's for pre-renal. The blood flow is reduced to the kidneys. For an intrarenal or an intrinsic injury, damage will be done to the glomeruli, the interstitial tissues, or the tubules. So damage done to the glomeruli, the interstitial tissues, or the tubules of the kidney. And then in a post-renal injury, this would be an obstruction to urine flow, like kidney stones. So in pre-renal failure, this is the most common type of acute kidney injury. It happens particularly in trauma, surgical cases, and critically ill patients. Pre-renal failure is caused by decreased glomerular perfusion, thereby causing decreased filtration. It could be result from conditions that affect the renal blood flow and perfusion. For example, hypovolemia. Within that is hemorrhage, dehydration, loss from the GI tract, burns, and wounds. Could be from low cardiac output, such as heart failure, cardiogenic shock, and MIs. When the reduced blood flow is caused by shock or hypoperfusion, the kidneys attempt to compensate by constricting renal blood vessels. This activates the renin-angiotensin-aldosterone pathway. And released antidiuretic hormone to get perfusion up to the kidneys. Unresolved ischemia can lead to tubular cell necrosis and significant nephron damage. This can lead to intrinsic ARF caused by ischemic injury. So pre-renal, if it's unresolved ischemia, can lead to intrinsic ARF. Pre-renal ARF is rapidly reversed when blood flow is restored and when renal tissue remains undamaged. Pre-renal failure can lead to intrarenal failure due to prolonged ischemia. These guys can also have an altered vascular resistance they can be like sepsis, anaphylaxis, vasoactive medications, and they could have decreased renovascular blood flow as a result of thrombosis. So in pre-renal failure, the kidneys normally receive 20 to 25% of the cardiac output to maintain our GFR, our glomerular filtration rate. That's the rate at which fluid is filtered through the kidneys. So a drop in renal blood flow to less than 20% of normal causes the GFR to fall. So less than 20% causes that GFR to fall. As filtration of substances by the glomeruli is reduced, less reabsorption of substances in the tubule is required, resulting in the kidney cells to require less energy and oxygen, and their metabolism slows. So as filtration of substances by the glomeruli is reduced, there is less reabsorption of substances in the tubule, required, resulting in the kidney cells to require less energy and oxygen, and their metabolism slows. So prerenal oliguria occurs because there is less circulating blood volume going to the kidneys. At this point, there's nothing wrong with the kidneys, and like we mentioned earlier, it's easy to reverse. All you have to do is restore the blood flow to the kidneys, and then you'll restore the kidney function. Prerenal azotemia is a reduction of excretion of sodium in the urine, increased water and sodium from the RAS system, and decreased urine output. So again, prerenal azotemia is a reduction of excretion of sodium in the urine, increased water and sodium from the RAS system, and decreased urine output. Again, prerenal can also cause intrarenal. If the poor perfusion is allowed to continue long enough, the kidneys will lose their ability to compensate, and then it will lead to intrarenal failure. So intrarenal failure or extrinsic failure, this is caused by kidney disease. It's characterized by acute damage to the renal parenchyma and nephrons. Parenchyma is P-A-R-E-N-C-H-Y-M-A. So it can be glomerular or microvascular. Within that, you can have glomerulonephritis, DIC, vasculitis, hypertension, toxemia of pregnancy, and hemolytic uremic syndrome. You could have acute tubular necrosis, where the primary cause is prolonged ischemia. This is where you have ischemia associated with prerenal ARF. It could be caused by toxins like nephrotoxic drugs, heavy metals, hemolysis, and rhabdomyolysis. Anyone want to take that one for me? So acute tubular ischemia can result in changes from kidney tissue. For example, infections like sepsis, drugs, and cancer. Tubular cells slough off and combine with other elements, such as red blood cells. This leads to blockages in the tubules, and it prevents urine output. Vascular disorders affecting the kidney, such as vasculitis, that is inflammation of the blood vessels. Malignant hypertension and arterial or venous occlusion can damage nephrons sufficiently to result in acute kidney injury. Rhabdomyolysis may account for 7 to 15% of all cases of acute renal failure. It's caused by the release of excess myoglobin from injured skeletal muscles. The myoglobin clogs renal tubules, causing ischemic injury, and contains an iron pigment that directly damages the tubules. So again, it's that clogging of the tubules with the myoglobin. Hemolysis, that's the red blood cell destruction. Releases hemoglobin into circulation with much the same effect as rhabdomyolysis. So the post-renal failure, this is where we get obstructive causes of acute kidney injuries. They're classified as post-renal. Any condition that prevents urine excretion can lead to post-renal acute renal failure. Benign prostatic hypertrophy is the most common precipitating factor. Others can include renal or urinary tract calculi and tumors. So kidney stones and tumors. This can lead to hydronephrosis, an increase in hydrostatic pressure inside kidneys, causing tubular blockage, which causes progressive decline in kidney function. So again, hydronephrosis is an increase in the hydrostatic pressure inside the kidneys, causing tubular blockage, which causes a progressive decline in kidney function. If it is relieved within 48 hours or 2 days, then the kidneys will come back. So we want to make sure to get this pressure relieved within 2 days of the onset. If it is not relieved after 12 weeks, the kidney will not come back. So the longer you wait, the more likely tubular atrophy will occur and kidney fibrosis will result, which is irreversible. I think that's a good stopping point. Next, what's today, Thursday, next Wednesday, we'll get into health promotion and maintenance.